Respiratory medical emergency. We'll be looking at chest trauma, specifically blunt chest trauma that causes the flail chest, or the penetrating chest trauma that causes a pneumothorax. The definition of a flail chest is going to be the result of fractures of three or more adjacent ribs in two or more places. This results in paradoxical chest wall movement, where the fractured area is sucked in with inspiration instead of expanding outward as normal, and ballooning out with expiration instead of collapsing inward as normal. A flail chest is usually caused by blunt trauma, and one of the most common causes is going to be a high speed vehicle crash. It can also occur from CPR where the ribs have a bilateral separation anteriorly from the cartilage connections without an actual rib fracture. Symptoms of the flail chest include that paradoxical chest wall movement, dyspnea, cyanosis, tachycardia, hypotension, anxiety, pain, an increased work of breathing, and it does require significant force to create this flail chest, so we always should be assessing for additional injuries. Treatment will be supportive. We need to administer humidified oxygen, definitely pain management, because we want these clients to be doing deep breathing exercises and coughing. That treatment, for the most part, will be geared to promote lung expansion to help prevent complications. So, pain is a big factor. We have to keep that under control. We'll do tracheal suctioning if necessary. It may require mechanical ventilation. Positive pressure ventilation is going to help stabilize that flail chest, but surgical stabilization in extreme cases might be necessary. It is also, of course, important to monitor vital signs and fluid volume status, respiratory status, etc., in addition to providing psychosocial support. So, a question. The nurse arrives in the client's room to discover the client is cyanotic and diaphoretic. Based on this information, what priority care will the nurse anticipate? Well, initially, whenever we have a change in client status, the very first thing we should do is a quick reassessment. In this case, that would include pain and the location of the pain, oxygen saturation, the respiratory rate and pattern, the heart rate, and blood pressure. And we need to determine if this is respiratory or cardiac, because these symptoms could be symptoms of a myocardial infarction. However, it could be due to that flail chest. We would also then initiate or increase oxygen therapy. We would elevate the head of the bed and notify that healthcare provider as soon as possible. This client is tanking on us, going south. They're deteriorating. We've got to get some more professional help in. So, next question. How will the care change for this client if there is confirmation the client has a flail chest? Well, these symptoms, remember, cyanotic and diaphoretic, are signs of client deterioration. So we're going to complete those interventions I just went over. The quick reassessment, initiating or increasing oxygen therapy, elevating the head of the bed, and notifying the healthcare provider. But then we're probably going to be intubating this client and putting them on mechanical ventilation. So we need to prepare for that. We also need to determine, is emergency stabilization of that flail chest portion required until additional interventions are able to be initiated, such as the positive pressure ventilations with mechanical ventilator. We can do that by placing like a folded blanket or a heavy pad on that area to help prevent that ballooning of the lung. So a pneumothorax is air in the pleural space. It causes a loss of negative pressure in the chest cavity and a rise in the chest pressure. That is going to start causing a reduction in the vital capacity of that lung. In other words, that lung is going to start collapsing. And it may just be a partial collapse, it may be a total collapse of that lung. A pneumothorax is often caused by blunt trauma or potentially a penetrating wound from a stabbing, a gunshot, maybe complication of a medical procedure such as placement of a central venous access device. Stop and think where those lines are going, and they're using sharp needles, and if they are not careful, and even if they are careful, sometimes they can actually puncture the lung. Or rib fractures. Rib, broken rib fractures could potentially um, perforate the lung tissue and cause a pneumothorax. But pneumothoraxes can also occur spontaneously. A pneumo can be open, where the pleural cavity is exposed to outside air through that open wound, uh, in the chest wall, of course, or it could be closed. Now, if bleeding occurs into the chest cavity, we call this a hemothorax. Hemo standing for blood. If it's less than 1,000 mLs of blood, we consider that a mild hemothorax. If it's greater than 1,000 mLs of blood, we consider that a severe pneumothorax. And then we have a tension pneumothorax, which is a complication of a pneumothorax. It occurs when air enters that pleural cavity during inspiration, but then it does not exit during exhalation. So that air is going to continue to enter, but not exit with every breath. And that's going to increase that air pressure inside the chest. It will completely collapse the lung, and it will start to compress the blood vessels and can lead to decreased filling of the heart and decreased cardiac output. Eventually, and sometimes it doesn't take very long, it will cause compression of the heart, and it will shove all of the organs within the chest to the opposite side of the pneumothorax. We call this a mediastinal shift. And with that mediastinal shift, literally everything in the chest cavity is shoved past the midline. And that includes the trachea, because remember, the trachea is going to be attached to those airways going into the lungs. And when you start seeing that tracheal deviation, that is going to be a strong indicator of a tension pneumothorax. A tension pneumo is fatal if it's not promptly detected and treated. Symptoms of a pneumothorax include reduced or absent breath sounds on the affected side. If it's just a pneumothorax, we may see the hyperresonance with percussion, but if it's a hemothorax, we'll have that dull sound. There may be minimal to no chest wall movement on the affected side. Dyspnea. In severe cases of a pneumothorax, we will have that tracheal deviation and mediastinal shift. but most frequently with the tension pneumothorax. Additional assessments that we may discover with the tension pneumo is we have severe respiratory distress and cyanosis, distended neck veins, and hemodynamic instability. As far as diagnostics, chest x-rays are going to be very important, CT scans, and ultrasound. And how do we treat it? Well, the goal is to evacuate the air or blood from the pleural space. If we have an open chest wound, until provider treatment is available, because not just anyone can put a chest tube in, we should cover that open wound with a sterile vented dressing, meaning we take a non-porous gauze to the client's wound on 3 sides only. And this is going to allow air to escape but not re-enter the pleural space. Or if you look at the picture in your slide, you can see the device that is forming a seal around the open chest wound, and it is allowing air to escape but not allowing air to go back in with inhalation. Now, if the pneumothorax is mild, it may not require any treatment other than monitoring. Otherwise, oxygen therapy and chest tube insertion. The chest tube will go to a water seal drainage system, and it may be connected to wall suction. This will stay in place until that lung reinflates. The nurse should monitor for signs of leakage and should monitor the drainage. Serial chest x-rays will be done to monitor lung reinflation. You have to keep that drainage system upright and lower than the insertion site. And I've placed a picture of that on the left side of your screen. We need to keep chest tube clamps in the room in the event of a leak. And in case it becomes disconnected for some reason, if we don't have the chest clamps available for some silly reason, we can put the end of the tube in a cup of sterile water, and that will help prevent uh, sucking air into that pleural cavity. We will also put a dressing around the chest tube insertion site, and that dressing will be occlusive. Now, since it's a very large tube, it will usually be wrapped with petroleum gauze and then covered with regular gauze to help prevent air leakage. We're also going to provide pain control, pulmonary hygiene, monitor those vital signs and respiratory status, and with the tension pneumothorax, prior to doing any of those other things, it will require a needle thoracostomy to release the air. Again, that is a life-threatening situation. We have to treat it immediately. Complications of pneumothorax, well, the tension pneumothorax. The other one is subcutaneous emphysema. This is where air is leaking into the tissues. And if you look at the picture in the middle of your screen, you see the significant facial edema on this gentleman. So it can cause edema where that air leak has occurred. And then when you palpate that area, it sounds and it feels like Rice Krispies. You feel and you can hear a pop, 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 or like the popping of bubble wrap. The body will gradually reabsorb this air, but in severe cases, it may require the placement of a tracheostomy.